This SUDISA meeting, SUD Intake Screening and Assessments Work Group. Just want to go over the disclaimers as usual. So this meeting is being recorded and it will be posted to the HCA website on a webpage dedicated to this work group. This recording is open to public disclosure via that webpage. So please do not disclose any private or confidential information during the meeting. If you are here as someone who is not a member of the work group, you can provide public feedback. In fact, that is more than welcome. But just to let you know, this work group is not subject to the Open Public Meetings Act. So members of the public, again, are welcome to attend and observe the SUD Intake Screening and Assessment work group meetings, but meeting participation, including use of the chat, will be limited to work group members only unless otherwise specified. For example, if you are attending as a guest participant, panelist, presenter, etc. So if you are not a committee member and you would like to provide comment or questions for the work group's consideration, please email hcaesb5476@hca.wa.gov, and the work group administrator will share your message with the work group. All right, and with that, we'll go ahead and move into roll call. We'll see who's here today. I know Teresa Adkisson is going to be joining about 30 minutes late. Arthur Andrews.
Here.
Great, good morning. And so sorry for everyone who doesn't know, I'm Michelle Martinez. I am I was the SUDISA work group administrator, and I will be helping our new SUDISA work group administrator the next few meetings. But anyway, just wanted to introduce myself to anyone who wasn't familiar already. And we'll keep moving down the roll call. Maida Hogan.
Good morning.
Good morning. Michael Langer is out. Ruth Leonard. Gail Martinson. Sarah Melfi-Klein.
Good morning.
Good morning. Melanie Oliver. Eliza Tharp. Tony Walton. Rachel Downs. Brianna Peterson.
Here.
Good morning. Kathy Asada.
Good morning, I'm here.
Good morning. Bethany Barnard.
Good morning, I'm here.
Good morning. Brandy Branch. Elizabeth Bridges. Tiffany Colombini. Dallas De La Grange. Charnay Ducrest. Alicia Egan.
I'm here. Sorry, I couldn't find my unmute button.
That's all right. Good morning. Dominique Fortson Jordan. Trina Galacci. Sarah Gillard.
Good morning.
Good morning. Anna Hartu. And I think Jackie Jones is not able to attend today. Kutsia Khan. Garrett Leonard.
Here.
Good morning. Philip Mays. Molly Martin.
Here.
Good morning. Beth Myers.
Here.
Good morning. Katie Ramos.
Here. Good morning.
Good morning. Cara Reedy.
Good morning, I'm here.
Good morning. Carrie Reinhardt. Amy Rouge.
Here.
Good morning. David Sapienza.
I'm here. I will have to leave about 15-30 minutes early, but I'm here.
Oh, okay. Great. Thanks for letting me know. Bergen Stark. Wayne Swanson.
I'm here.
Good morning.
Good
Adrian
morning.
Tillery. Angela Tonkovic.
I'm here. Good morning.
Good morning. LaShanti Turner. And Daniel White.
Good morning.
Good morning. All right, great. Is everyone seeing me in like a stadium seat, or is that just my own visual?
That's just you.
Okay, good. Okay,
Blurred.
good. It's a little weird.
Oh, I see
I
it,
don't know what
Michelle.
Teams is
I'm
doing,
not.
but it's doing that
Yeah.
like, yeah, gallery view or something. Okay. It's distracting. All right. Thank you everybody for bearing with me through the normal meeting opening bits there. So we do have a couple of group announcements. As I mentioned earlier, we've got a new administrator for this work group, Kelly Sendaker. So I need to add Kelly to the attendees list here. Kelly, are you on? Hi, Kelly. Do you want to say a bit about your background and what has led you to this role now? Sorry, I'm putting you on the spot here. We did not discuss this before. Oh, you're muted. Sorry.
Yeah, it's no problem. Hi, everybody. My name is Kelly Sandaker. I've been in the field of addiction for about 12 years, behavioral health. I've worked in prevention and intervention with adolescents. I've worked with adults and outpatients. I've worked for Department of Corrections for Spectrum, SUD, and then I've also done inpatient residential working at CMAR. So I've done inpatient a lot. And I've done, and most recently, I was just at Cascade before it was closing. So I was there all the way until like almost the last day. So I was at Cascade. So that was a psychiatric hospital where I helped run the SUD program there as well. And I really wanted to get into more of a way of changing and molding policy on a bigger level, and that's why I applied to the HCA. And I'm really happy to be here and see all of y'all here. And yeah, and this stadium thing where we're sitting next to each other, I've never seen this before, so it's kind of cool.
Oh, you're seeing that too.
Yeah, I'm sitting next
Yeah.
to you on the thing. It's cool.
That's an
Yeah,
that's an
it's
option
weird.
you have. That's an option you guys have under one of your buttons. You
Yeah.
can
Yeah, it's
change
called
it.
together mode. I need to figure out how to turn it off. It's distracting to me.
Michelle, I think if you go to view, the option is under that. It says gallery
Oh, there we
speaker
go.
together mode.
I just
Yeah.
need to select speaker, I think, and that will narrow it down. Okay, cool. I'm glad you're enjoying it, Kelly. All right. And then the other announcement that I had is we're building the SharePoint site for everybody to use to collaborate on various documents. So that should definitely help with things like putting together that table. So instead of having separate drafts moving through email and then, sending them back to me to update, we can all be working on the same like web-based copy, and contribute comments and build the various documents and recommendations together that way. So that will hopefully help streamline the process together also. So I'm excited about that. That should be ready in the next week or two, I think. So hopefully by the next meeting. And we're still waiting on final approval for the charter. So just know that that's still on my radar, and I am going to send that out to everyone when that's finalized and ready to go. All right, so with that, the next item is reviewing our work to date. So what I was thinking when I was considering how to spend our meeting time today, it seems that we've spent the past 3 or 4 meetings now doing some light brainstorming around solutions and also getting a sense of the landscape out there around intake and assessment, and especially how it varies depending on the different services and entry points that people are coming into services by. And I would love your thoughts before we get into this about what makes sense to you in terms of organizing the recommendations. Like, for example, how do we start to break this down so that we are focusing yeah. How do I phrase this? How do we break this down so that we can start to formulate specific recommendations to solve the issues? And also, do we need to do more information gathering before we get into that part of the process? So you've got the ideas and considerations document that has been tracking the various ideas and considerations that have come from conversations so far. And then there's the table that we worked on the last meeting that does a kind of cross compare of various services in the behavioral health field and the intake and assessment process for accessing those services. So if we want to take just some time to review those documents on your own, that's great. But then as soon as you're ready, please raise your hand, unmute yourself, and would love to hear your ideas on how to start organizing this information and forming recommendations. Also, as you're reading through, if you notice you're not clear on what something means, that this is a great opportunity to raise your hand and ask for clarification around something. Yeah, Kathy, go ahead.
So I'm not sure if this is what maybe you were looking for, but I'm definitely seeing some, like, within the desired outcomes and recommended changes, I'm seeing some definite themes
Mhm.
that can be maybe sorted out. So there's themes regarding like systems, like payer systems, and maybe clinical systems, and screening, and things like so definitely some themes that can be split with the desired outcomes kind of placed under each category, um, in terms of like what are some system changes that maybe we can look at, what are some training needs we can look at, what are some screening tools we can look at, what are some maybe even, I would say, cultural stigma things that we can address in terms of community changes. That might be a big ask, but um, the use of peers would be its own. So definitely some common themes that we can place the recommended changes into different categories. Would
Yeah,
be a
that's
nice,
exactly what I was
yeah,
hoping for actually, Kathy, is to
yeah,
to see what, because I have my own interpretations, right?
yeah,
But you're more subject matter experts, and so I want to see what's jumping out, for you in terms of the themes and what we could build, start to kind of categorize some recommendations around. So
processes,
yeah, okay.
yeah.
Um, and any specific kind of processes, just so we can narrow that down a bit.
Um,
Like intake and assessment. I mean, I know that doesn't narrow it down too much, but
it
is
does,
that
yeah,
what you
because
were,
that's kind of the whole theme of the entire um, group. Um,
or for a specific service? Like if you look at that table, right, is there a process?
yeah. So looking at it in terms of I would say maybe the process is like when we're looking at maybe from the systems point of view, streamlining how can we get the different systems to um, play in the same sandbox so that we're not doing 12 different processes at one time, so that we can maybe keep it a very simplistic process to start with. And then as we need to add on, as the relationship grows with the client, we can then add on more things. But what can we do to start quickly to get the client in the door and develop develop the treatment goals, develop the plan, get the client stabilized, and then add on more of the lengthier processes that, because I know even for my quickest clinicians, from start to finish, it can take an hour and a half from start to finish. And for some of our clients, that can be forever.
Mhm.
So what can we do to at least get them in the door so that it doesn't feel like forever?
Yeah, yeah. Okay, great. So what we've got so
Yeah.
far, and Kelly, I see your hand up. So we've got payer systems, clinical systems, screening processes, use of peers, streamlining pre-service screenings, and then having lengthier assessments after the treatment has begun. Yeah, Kelly, go ahead.
Yeah,
Oh, I'm
I
sorry,
was,
there was a hand up. I'm sorry, Kelly, there was a hand up. Someone, Elizabeth, go
yeah.
ahead. Sorry about that.
Thank you. I don't know why I'm blurred out there. I appreciate everything that was said. Kathy, I used to work in treatment centers, and I worked in DOC. Welcome, Kelly. So I understand, but now I work in a medical center, and so the doctors do not have any working knowledge of ASAM criteria. It's not part of what we do or what the medical providers do, like in the hospital, the emergency room or the hospital or the clinics. So I work in all three settings. I just need that to be a part of this. Like the medical system has very different language for assessment, screening, diagnoses. Well, we do use DSM for criteria for diagnosing addiction. Some, not all. So just wanted to make sure that that's part of the theme, the streamlining pre-service. So I sent a patient yesterday. He was in the emergency room the day before with a very high level of alcohol, and he wasn't eligible to go to a detox, even 3.7, until he was medically stabled. And so he was sent from the ER upstairs to the intensive care unit for an overnight to be observed because the doctors didn't feel like the detox center in any of them would be able to medically take care of him. And so the following day, he then was transferred to withdrawal management behavioral health facility. So I just need to say that. Thank you.
Okay. Yeah, thank you. And I've added that to the considerations document so that we
Right. And
have that captured.
So there was no ASAM assessment done, right? He just went from the medical to withdrawal management, and he is already in an online outpatient program, and so there's I guess there's always going to be patients that fall outside the mainstream road that we've all been taught to bring them through, you know, in the treatment industry. So thanks.
Yeah. Thank you. I'm trying to look for, okay, so actually, yeah, Kelly, go ahead with what you were gonna say.
Yes, I'm just making sure to get used to taking me off the mic or whatever. I'm muting myself. I was gonna say something real quick, and it might go along with this. And remember, I'm new to this group, so also too, maybe be in the beginning of the whole process, identifying which patients need what. For instance, like a critical access patient might need something more than, let's say, a DUI patient for outpatient, right? Like a person who gets DUI might not need treatment services right away. They might, it depends on the situation, but being able to identify which need, and maybe there be two different processes. Maybe someone who's critical access who says, like, the clinician, the doctor, whoever it is, says this person is critical need. That means we need to do a screening in this. I'm just giving an idea here that we can talk about later. I don't know what we'll form into, but it's just an idea I had that maybe there is two different processes for determination by the clinician or the agency as they see fit for the people they serve.
Yeah, so how does that, like, what is the current situation compared to what you just said? Just so I understand, like,
Yeah.
how we don't have that already. Yeah.
Yeah, so right now, if someone goes into any outpatient, everybody is, I mean, depending on where you go. So if there's any agencies here, I know that everybody has their own process, but some agencies run it that everybody's treated the same. You come in, you do intake paperwork, then you make an appointment for an assessment. Some people run it where if they do walk-ins Monday, Wednesdays, and Fridays, everybody walks in. If there's a slot, there's a slot. If there's not, then, come back tomorrow. But a lot of people have a lot of slots. So, I mean, but right now it's not necessarily like I can't, as a clinician, be like, oh, well, I think you're critical access, so I'm gonna do a quick assessment on you for getting you in a detox. I have to do everything I would do for anybody else, diagnose you, because it has to do with the billing of everything. So I mean, but yeah, that was just an idea I was kicking around right now. So, but yeah, that's how it kind of goes right now.
Okay. Okay. Yeah, that's helpful to know. Um, I see a hand up for Angela. Yeah, okay, Angela, go ahead.
Yeah. So I know we're kind of already in the work, but I remember you had mentioned maybe a couple meetings ago about possibly having like a walkthrough of ways that clients go through the process. And I think that'd be helpful, just speaking for myself. Like I know a lot about how the process works in my particular area, which is, in emergency rooms. And so I don't want to backtrack necessarily, but I think it might be helpful for all of us to have like a well-rounded idea of how maybe a couple different pathways that folks are going through. From first getting the idea that they want to get into treatment, and then is that through an ER? Is that like someone on the street? Is that someone going to like a peer support group? That would just be really helpful for me.
Yeah, thank you. I can almost guarantee you're not the only one that would benefit from some more discussion around that. Okay, I'm not seeing any other. Oh, no, there is a hand. Yeah, Dominique, go ahead.
I was actually going to piggyback on what Angela was saying, in that I'm hearing it's starting to feel a little convoluted on a lot of the different processes. So maybe exploring exploring specific pathways based on entry could be helpful, because we all know that different agencies that provide different services do things a different way, but possibly creating or looking at or thinking about there being a generalized process based on the path of entrance. If that makes sense.
Yeah, yeah. I'm just thinking right now, whether to spend like to pivot the meeting time to focus on working on that instead of like themes and recommendations. But I wonder if maybe we will need a little bit of time to organize those like flow charts, or anyway, I'm just trying to figure out how to move forward around that. And Teresa says in the chat, the ASAM criteria 4th edition will offer a quicker pathway. We will implement this January 2026. One of the recommendations this group could have is that our state fully maximize the flexibilities offered by the 4th edition ASAM criteria. And then question, are doctors and nurses going to be trained on how to implement ASAM criteria? I believe so. I believe I've seen funding for training. But someone else would need to speak to confirm that. Great question, Elizabeth. So for our note taker, we'll need to follow up with an answer to that.
Yeah, and I can speak a little bit to that, Elizabeth. So we will, hi, this is Teresa Claycamp. It looks like I'm muted still. Hopefully you guys can hear me. I think you can. We will be rolling out a very robust training plan for the state. And so we're working on that right now. The legislature did fund us for some training. We do need to prioritize our behavioral health agencies though, right? So we want to make sure that those folks get the training they need. And we'll have, we're looking at training opportunities, through into 2025 on the ASAM 4th edition. So, and we'll offer different avenues, some for like clinicians actually doing ASAM, using the ASAM criteria. We're also going to offer training for more like clinical supervisors and administrators. So it's in the works. And so we'll offer more information as that rolls out.
Thanks, Teresa. All right. So let's see. I wonder if for our breakout rooms today, it might make sense to, like, if everyone can pull up that table document with the different services and take a look and maybe you've been able to identify a particular service pathway that seems like that it's kind of high barrier or takes a long time, or that it would be just one that you would like to see the pathway change in some way. If we could pick maybe a couple of them today and then go on to breakout rooms and talk about the current pathway for the patients, like basically taking that row and drilling down into like what that pathway can look like for maybe a couple different people coming from different situations, so we can better understand at least a couple of these. Then at the next meeting, we can see what would change in that pathway based on the ASAM criteria. And if that fixes the problem, great. If not, we can start to build recommendations around how to improve that pathway for that particular service or treatment process. Can I get like thumbs up if that makes sense to people and sounds good? Okay, I'm seeing a few thumbs up and a few. Oh, I think maybe hands raised was getting mixed up with thumbs up. All right. So I don't want to move forward with that if that doesn't make sense to anybody. Please raise your hand and let me know if you have I don't know, concerns about that or a better idea. Even I'm definitely open to other ideas. Elizabeth, go ahead.
Could you repeat that and just clarify what you're asking for us to
Yeah,
do?
so here, let me share the document I'm referring to, just so we're all on the same page. So what I'm asking is for everyone to take a look at this document, which is attached to the meeting and emailed out yesterday afternoon. And it's not fully filled in yet, right? But the first column is the different types of services, and then we've got required intake or screening prior to receiving the service, and then anything that happens after the service has been initiated, and then additional notes. So what I'm wondering from you all is, are there specific services that, like particularly ones that require the ASAM or other kind of lengthy assessment processes, that are the ones that you want to focus on streamlining or making more accessible, reducing barriers, that kind of thing, that like right now it's overly burdensome or complicated or just high barrier to get into the service for whatever reason. So picking a row or two of a service that you want to focus on for improving, and then we can use the breakout rooms to dive deeper into what the patient, like the experience is for pathway through that, getting to that service. So we can identify the current state of that process now, because that's the first step. And maybe that's all the further that we get today. But I know that, what we have in this row is not comprehensive. And so what I'm hoping to do is take a couple of these and really build them out so we understand more fully what the patient experience is like moving, like trying to access that service. And then in the next meeting, we can see how the new ASAM criteria might address some of the concerns or challenges there. And if it doesn't, start to formulate recommendations to the legislature about how to improve it. Does that answer your question, Elizabeth, or did I muddy it up even more?
No, that's, I understand. Thank you.
Okay.
Just a matter of who's going to work on what row. to,
Right,
in what
right.
breakout rooms?
Yeah. So I'll take this down and I'll pull up another slide and we can maybe do this as kind of a nomination process. So if someone wants to raise their hand and say, I want to work on residential inpatient treatment, then that will be an option for a breakout room that other people can join. And someone else says, I want to work on but I don't know, hospital inpatient units or outpatient medical setting. I don't know, whatever someone wants to work on, right? So if someone just wants to raise their hand and say, I want to work on that, we'll add it to an option for breakout room. And once we have, 2 or 3, then I'll create the breakout rooms and we can talk about them in more depth. Yeah, David, go ahead.
I'm happy to work on any of them. This might, I don't want to muddy things more, but I'm having trouble deciding from my standpoint what would be most helpful for me to work on, because my expertise in providing the care is in the MOUD medical side. So I have a lot of input on what the barriers or things, how we function. But then I'm on the outside of trying to get people into inpatient or withdrawal management. And so I have a lot of experience, not expertise on providing that care in our current system, but on what the barriers are trying to get someone into that care. And so I kind of don't know which place to go, like the
Yeah.
place where I know what's happening once someone's engaged in that care and how they get engaged, and if that's making sense. So I'm happy to do
that makes
either. I just
a
don't know
lot of
which one's
sense.
most helpful.
Yeah, no, that makes a lot of sense. And I think at this point in the process, I would love to have folks in breakout rooms where they can speak to what the current situation is with expertise. And so if there's a overlap between your area of expertise and an awareness of the a desire to work on the problems in that area, then that would be the place to nominate yourself to work on it or to have that be an area of focus. And we can repeat this process in future meetings, for as many of the services that we need to, right? So it's not like we just pick 2 today and then we don't do it again.
That's it. Okay.
Yeah.
I just wonder, Michelle, Teresa, one of the themes that keeps popping up though, right, is the medical space interfacing with the treatment space, right? The pathway from, like, if somebody comes in through the door in the medical side, whether that's primary care, the ER, what have you, and then trying to get somebody to treatment, right? I feel like that's come up quite a bit so far, and I don't know if there's if there needs to be a focus on that. And a combination of some treatment folks and medical folks kind of diving into that. I don't know. I'm just throwing that out there. It just seems like there's been a couple times where that's been brought up, and then with treatment, right? It's like those of us in treatment, we can talk about the issues, like whether that's residential or outpatient or what have you, right? The pathways and the issues with that. But I feel like there's this theme with the folks landing in the medical door and trying to get to the treatment door. And maybe I'm off base, so I want folks from the group to lean in on that.
Mm. Yeah, Elizabeth.
Yes, so that's one of the issues. I want it to be resolved. I want someone, because I have people that come in through these different medical doorways, and because of the terminology and the requirements, and I don't think I don't know if it's a policy issue, but there's a understanding of what medical people do and how to, you know, get someone to treatment. They just send a referral, but the treatment centers are, it's not easy to like get into a treatment center in the middle of the night if you're in a hospital emergency room, right? There's just a language barrier between medicine and treatment, SUD treatment. There's a, that's why I was asking about the ASAM criteria. But what I noticed in the emergency room and with the doctors here in our hospital, the hospitalist is, and the nurses and the MAs and all the support staff is, they are confused about what is needed to get someone who comes in, they want to go to detox. And so they're confused by what the requirements are to get that person to detox. I'm trying my best to help with that here, and I step in and I take care of that a lot of the times, but I'm not here 24 hours a day, 7 days a week. And so a lot of people fall through the cracks and end up coming back and coming back and coming back. And I'm sure you all understand what I'm talking about. I just would like for there to be a way that when, well, never mind. That's all I have right now. A streamlined way for someone who comes into the emergency room or to the doctor's office and wants to go into treatment. And I think the biggest barrier is that the treatment centers a lot of times have appointments 2 weeks or more out, and that the first thing they have to do is fill out and sign and read about 20 or more different forms, including several different releases of information. So there, that's all I have.
Okay. Okay. So I'm hearing now that like release of information paperwork is actually another like barrier and challenge to consider in that process.
Yes. I sent a patient recently from the emergency room over to the SUD treatment center, and I was told when I called and spoke with the treatment center that they would take care of this patient who was wanting to go to detox. And what they did was tell him he needed to go get an insurance card. And so that was over 2 weeks ago, and he still is not in a detox program.
Wow, okay. So sometimes getting an insurance
Alright.
card is another issue. Sorry, go ahead, whoever was speaking.
Yeah, can I clarify though, he had coverage, like insurance coverage, they could see that, but
He
they
had
insisted on
insurance coverage, yes. I think it's lack of
Oh.
training and providers, well-trained people. I spoke to one person, but then the person that spoke to the patient when he walked in was someone who is new, and it, you know, their heart is in the right place. They're trying to do the right thing, and they're told, well, the patients need to have an insurance card, but we know that their insurance is visible on this in the system. This person has coverage, yes. So he just didn't have the card. So I guess it's training and workforce issues.
Yeah, I was gonna slightly modify just saying paperwork in general, paperwork and things that patients or clients need to sign. Not just release of information, but any additional form ends up being a barrier for some people.
Okay, and just so I understand a bit better, when we're talking about connecting someone from the medical side to like community treatment options, is it sounds like one of the issues is the paperwork required, just like on the intake side of the medical end of things, and then uh, lack of clarity about what is required for the community service, the community-based service. Like, for example, there was that person that you were trying to connect to detox or withdrawal, but it was unclear what was required in order for them to be accepted to that um, service or program. Is that right?
No,
Okay.
that person had everything they needed, including the desire to get into treatment and the treatment, and they had insurance coverage. They just didn't have the card. And the person walked into the outpatient treatment center where they would, where I was assured they would have their need met to enter into withdrawal management and further treatment, which includes after the person goes to withdrawal management, they go to sometimes inpatient treatment. And then after inpatient, it's always recommended that they do outpatient treatment. And so a lot of times it's at the beginning of the whole process is facilitated in an outpatient treatment center where the person does intake. But this person needed withdrawal management. They were taking fentanyl and they wanted to stop taking fentanyl, which is a huge, uh, you know, wonderful thing because that person decided, they want to live. And I sent them to a treatment center who told me they were going to be able to take care of them. And then they had someone who was at the front desk who there was a misunderstanding, I guess we could say. And
Mm.
I think there's a lack of providers and services, and that's one of the issues. There's not a lot of availability. I dealt with 4 or 5 different detox centers in one day and had the process going, and then the person ended up going to a completely different facility. So there's a lot of issues, a lot of barriers that need to be resolved to make this a streamlined process. And I know we're trying to get in the breakout rooms. I apologize.
No, it's all right. This meeting is flexible. Breakout rooms were an option. We don't have to use them. Um, so yeah, no worries about that. Amy, go ahead.
It sounds to me, for lack of a better word, and it's on our release, it's about continuity of care. There's difficulties, and I experienced these as well, taking patients directly from the hospital setting into our treatment facility. That continuity of care does have its own set of barriers with needing specific releases signed, which I don't know how you get around that, but it can be really difficult to get releases where they need to be in time. Also, we have somebody who is at the we have a couple people working within the hospitals, and even for them, part of getting into treatment is having that diagnosis and that assessment. Sometimes you have to send that to an inpatient treatment center, XYZ. It can be very hard sometimes to even get that patient to be able to do that assessment. They want to go to inpatient directly from the hospital, but an assessment is a private thing, and it can be hard. What people are saying is true. It can take an hour and a half to 2 hours to get through an assessment, and when you can't get that private time with the client in the hospital because they're being released very quickly and need somewhere to go, it can be very hard to coordinate all that. So like a provisional, to me, when I hear these things, I think of like a provisional diagnosis. If there is some way to do a provisional diagnosis by whether it be the medical provider or someone to get them into the services that they are needing to access. And then the full assessment can be provided if they're not going the route of potentially detox. Maybe they don't need detox before treatment. I mean, there's just so many different things you can't account for. But the continuity of care, and yes, detox can be very hard. There has to be a bed. All our detoxes are walk-in. But again, it's or the ones we deal with locally are walk-in. So again, though, if there's not a bed available, there may not be a bed available that day. We don't run into it too much, though.
Okay. Thanks, Amy. Wayne.
Yeah, I think from a residential setting, I think I mentioned this in previous meetings, we get authorized now for 3 days, and that gives us the flexibility to do that ASAM assessment up front. And I think most people who are referred to, well, we have level 3.5, qualify for level 3.5. So I don't know what sort of way we can encourage residential facilities to take that burden on, because it is a burden to do that full assessment. It is a staffing issue. I know that's been mentioned before. It does take time, but really that is one of the ways to get people in, because that can be a huge barrier. You have that very small window of opportunity to get someone into that level of care. And so I don't know what kind of recommendation could be around having residential facilities exercise that 3-day pre-authorization space, so they don't require a full ASAM to get in the door assessment. But the other thing is bed availability. The 16-bed rule is really challenging. We would love to expand capacity here, and we're looking at different ways, but that 16-bed limit is really challenging. So of course our beds are often filled, and we work hard to get people in quickly as soon as one opens up. But that is another just capacity issue that is an outside thing that makes it difficult.
Yeah, thank you, Wayne. I've noted the 16-bed limit and like barriers and challenges around that. And then, gosh, sorry, I'm not catching everything. There was something you said about, what was it that you were saying about pre-authorization in order to be able to like skip over
Yeah,
the
so
longer assessment?
I put that in the chat. I put that in the chat. It's based off
Oh,
of
great.
2642 legislation.
Yeah.
Sorry, Wayne. Go.
No, that's fine. That's great. Thank you.
Okay, perfect. Let's see. And then Eliza, you had your hand up, right? Did you still want to say something?
I was going to bring up the 2642 legislation, and just seeing where, if there was still concerns regarding that piece of things, because when we hear, because this was implemented back in 2021, and it does allow for the at least 2 business days excluding weekends and holidays for withdrawal management, and then 3 day, for residential, and then for 3 days in a behavioral health agency for withdrawal management services, and that's 3 calendar days. So we just kind of wanted to hear, like, if that's still being received as a barrier from the payers, or is this more on the the agency side of like requiring certain, I'm hearing a lot of intake documentation even when someone's in the ER. I do hear the bed availability, but outside of bed availability being a factor, was there more pieces there that we're looking at specifically related to the 2642 barriers and that were supposed to be alleviated?
Yeah, I see Teresa's hand up, but Wayne, if you wanted to respond to that first from Eliza.
That would be great. So from we have an RTF here. No, it's provided us more flexibility. I think it's the intake process of the ASAM assessment which creates the barrier internally. So again, having a more streamlined assessment or intake process ultimately would be better for us collecting that information in a more streamlined way, because even when someone comes through our doors, they may be just out of withdrawal or in that late phase where it's difficult to spend an hour and a half with someone doing that same thing. So it addresses the same issue about the sort of weighty burden of our normal ASAM assessment. So, but it is helpful in that we can get that person in the door quickly, in a way where we don't have to make them wait.
Gotcha. Thank you.
Okay, and thanks, Sarah. Sarah shared a fact sheet for the 1115 SUD IMD waiver in the chat to answer the question about the 16 bed limit. Thank you. Yeah, Teresa, go ahead.
Yeah, I just really appreciate Wayne's comments. And I think that is something, I think the idea with 2642 legislation was to really make sure that the pathway to detox and or residential was paved in a way that was more streamlined, but the burden of the assessment is still there. And so I think we do need to, that is definitely something to hone in on. I do think maybe some of the ASAM 4th edition, is building in withdrawal management to some of the residential levels of care. So you're going to see that in the new ASAM, which could create a quicker pathway. And then the 16 bed limit piqued my interest. So what that is, folks, is there is a exclusion with Medicaid where Medicaid cannot be used for stays within what they consider an institution, which can be over 16 beds. And so you see in our whole treatment continuum a lot of 16-bed facilities, which are really inefficient. But the good news on the SUD side of the house, and when I say inefficient, lack of economy of scale, good news is what was just posted is that we do have a waiver in place with CMS on the SUD side that allows us to have facilities larger than 16 beds and to use Medicaid for services there. So we have that solidly in place. The mental health side is a little bit more complicated than that, and some of you may actually have blended services. So the mental health waiver for IMD status is a little bit more nuanced, and I don't want to waste time going into that. But if the 16 bed is a barrier, we probably, something that we could kind of dig into and maybe, because I think sometimes there's some misunderstanding around the IMD exclusion rule. And just know that at Healthcare Authority, we're working on some technical assistance materials and a web page and other things to help folks understand it a little better because it is confusing. So I'll stop there. Thanks.
Kelly, go ahead.
All right, make sure my mic was off. Okay, there we go. So one thing I've noticed too is that I went from being a program manager to CMAR and then program manager at Cascade, but I was also still seeing patients in detox. So I had to get people into residential treatment. And what I found is that I was around when 2462 was created, and I actually accepted a patient from the street after it was approved, directly from the street. He walked up, he had state insurance. I got him right into inpatient right there that day, because the law said I could, and I knew I wasn't going to get paid, and nobody was going to say anything. But when I had to get people from detox to residential, and people had beds, but they had this list of criteria for me to get them in. I was like, you know, there were some facilities that only required like one sheet of paper to get someone in. They would just, hey, answer these questions. We'll take your person. We'll do the assessment on our side. But then I found some people, some residentials were like, yeah, we still want the assessment because we're going to use that to send to the insurance company because it's really burdensome for us to have to do that assessment in 3 days. And so I think that I don't know how we can get residential treatment centers to be more encouraged to, instead of an assessment, more of a screener, because there's certain things you want to screen for to make sure you can handle that person, because there's just certain things. Like I worked in a facility that didn't have an elevator. It had a waiver. It didn't require to have an elevator, so we couldn't take people in wheelchairs at residential. So, that was one of the questions, like, hey, just letting you know, this is one of our barriers. And so I don't know how we can create this, but I do think that residential, there should be, and maybe it's about increasing workforce and everything, and it could be liability. Some people, they don't want to take a person unless they got all the assessments, the ROIs, the treatment plan from their outpatient and everything, because they're worried, like, what happens if this person gets here and something happens and I didn't have all the information, and I'm worried about the liability of everything. So I mean, I've seen it done a couple different ways, but yeah, I like this conversation where it's going for sure. So I just wanted to share that a little bit.
Yeah, thanks, Kelly. We still have about 24 minutes if we wanted to utilize a breakout space, but it does seem to me like the next, like maybe what will make the most sense for the next meeting is, or the next several meetings, is to pick a specific service and really make sure that everyone has the information that they need to be educated on the process around that, how the ASAM may change the process around that, what's required on the patient's end, the provider's end, like really, really drill down into one specific service and the intake and assessment process around that. And then from there start to form some recommendations. But it seems like we will get the most traction if we're focusing on a specific area at a time, because there's so much, it's easy to bounce around and for things to be related to one another and to, conversation to, I don't know. I don't know if the rest of you feel this way, but it seems like we're gathering so much information still, and it's great, but it's time to start kind of organizing and drilling down into something that we can get on the same page around and start moving forward with, recommendations around it. And the way to do that is to make sure that we're getting like zooming in to something enough to feel like we understand it fully first. Is that just me? Okay, Alicia, I agree. Okay. Okay, great. I see some thumbs up on that. All right. So, yeah, and it sounds like maybe the first area to focus on, like for the next meeting, would be the transition from medical settings to community-based settings. And that, I know that's not just one service, but it's a pathway to focus on. So if so I'll be reaching out to folks that, just based on your area of representation on the committee, would have some expertise in that. Like maybe we can schedule an agenda planning meeting together, so that we're set up for a productive conversation at the next meeting around that. But if there's anyone that wants to be part of that agenda planning meeting, please let me know in the chat right now, and we can figure out what information needs to be sent out to folks to better, to fully understand the process, and any RCWs that are related, any, if 1115 is part of it, how ASAM might affect it, all of that. Okay, great. Elizabeth Myers, thank you. And Maida says, just want to add that barriers to SUD treatment come up through the outreach pathway as well as the medical pathway. Yeah. Yeah. So maybe actually right now, instead of these breakout rooms, we can decide meeting focus for the next few meetings. And then we can plan ahead with information around all that. So let me share my screen again. And I don't have all the dates of the meetings memorized, but this will be our next one. And then would love to hear, so for the meeting after that, do we want to focus on barriers related to the transition from outreach to community-based treatment? Or are there other, I just need ideas for the following meeting that you want to focus on.
Well, it sounds like, Michelle, and I'm really glad that they noted that you identified that in the chat. It sounds like the outreach pathway and the medical pathway are going to have a lot of similar themes. And I'm just wondering if we could, I mean, is it possible to have the conversations together? Because it sounds like there's going to be a lot of overlap. And it would be nice to identify that overlap. So I don't know if that's doable, but
yeah, I don't know about like time is all, but I mean, if it's just like, oh yeah, that applies to outreach too, and it's just a matter of identifying like, yeah, that's the same, that doesn't take much time.
I think a
But I
lot of
just
it's
worry
going to be
about
the
like
same barriers.
scope creep, right? Yeah, Liza? Sorry.
Well, I'm looking at the chat. A lot of people are saying that the barriers overlap. So it sounds
Okay.
like there's going to be a lot of overlapping similarities that people are gonna have.
yeah, and I think just part of it is identifying, like, when we say outreach, what do we mean? You know, outreach pathway, what does that look like? Let's identify that a little bit. When we say medical pathway, what does that mean? You know, just making sure that we are on the same page. And again, because language matters, and I think, Elizabeth, you brought that up several times. A lot of this is being able to speak to one another and understand each other, and that's part of the issue, the language.
Yeah. Okay. And we don't need to plan out the next 3 meetings, you know, just having the next one set is, you know, puts us in a good place.
I wonder if it would just be kind of good to hear what people took from that grid as like a priority, like a second, you know, like another priority, a focus. Oh, sorry, Brandy, you had your hand up. You were being polite. Sorry. Go ahead.
Oh, that's okay. I kind of going back to the meeting focus. I do think that that it's been mentioned in the themes, and that it's been mentioned consistently of what type of services can be provided prior to an intake or assessment. And there was some discussion around the new service that's available, mostly for inpatient or jail-based service, or people that are in those settings. Even though it was brought up on this meeting that it can be for people who are homeless, that's not clarified in the series. But back to the point being, what services can be provided prior to that can assist with the screening and this transition? I do think that SUD, you have two, aside from licensed mental health clinicians that were just recently added, you have two credentials, SUDPT and SUDP, other than a peer that can provide services that, that has a $300+ licensing fee on a regular basis. So I think that we can talk about the use of peers or the use of what type of services that we could utilize to facilitate this cross communication, access to services, getting people in. Because right now it's SUDPDs that can do this ASAM assessment only. That doesn't mean that we can't use peers or potentially other credentials that we might want to recommend to the HCA that could be utilized that can provide information around what's needed that a clinician needs for an ASAM assessment, or to collect some of the data that's needed to effectively assist people with going from hospital-based care into outpatient or inpatient settings. So I would just like the meeting to focus on recommendations for potential changes to the billing and or credentialing structure that would allow some of these things to take place with the limited staff capacity that SUD providers currently have so that's kind of a peer-based theme / a way to increase access through use of staffing. I don't know how to, I could probably just verbally process more, but I don't think that'll be helpful.
If you could help me just with the language around this, so I'm capturing it. So recommendations to changes to the billing and credentialing structure that can, I was hearing a couple of things. So leveraging what peers can do in the process, right? But then also there was something around SUDPs specifically, right?
Or even just maybe updates to the Siri that would be easier than re-credentialing process that would allow like a larger scope of like care coordination, the new behavioral health community care coordination service be allowable to provide between any system of care versus just for people that are incarcerated or hospitalized, or so maybe just expanding what could be billable services and who can bill those services without changing what's already trying to happen with the expanding agency affiliated credential. I'm not suggesting we go there. So I guess I would back that up to maybe Siri and allowing more billable services for SUD related services.
Yeah.
It's extremely limited on what can be provided prior to an assessment or intake.
Right. Okay.
And
Oh, sorry, go ahead, Eliza.
Just bringing attention to Teresa's chat about the expansion of licensed therapists working at an SUD BHA can also do the ASAM. That was triggered as of January 1st. So just wanted to bring that highlighted forward.
I also, an echo of what Brandy was saying, this is something we've struggled with. The peers, I'm so glad you brought that up, because doing medication first, this is a huge thing. Our people they're receiving medication and seeing doctors and things, but they're languishing until that assessment can be completed. We do have peers now, and a case manager, but we're always trying to figure out how to use them to get touches on the people that are new while they're waiting for their assessments, because again, that's a place we lose people, and not being able to bill for those services, or having at least a limited number something, is not beneficial to those patients in the way that we're providing services now. It's antiquated.
Sorry, guys, it's Teresa. I'm going off a little bit in the chat because Eliza and I are, Eliza actually is point for Siri, and I am involved quite a bit. And so that's the Medicaid billing guide for the BHAs, so the behavioral health agencies. And there is quite a bit that you can do before an assessment. I think barrier may be the reason why people aren't doing brief intervention. I'm gonna go out on a limb here, is that the reimbursement rates aren't lucrative. So I think that may be something to look at. And so I think one of the things is to really make sure that folks know all the different flexibilities. We pulled a lot of levers in January 2024 with SERI, and how we did that was a state plan amendment. And so there were a lot of things pulled lever-wise recently. And so making sure folks know what those are, and then what else can we do, right? What else do we need to do?
All right, so this is really great because I think there's so much education, just mutual, need for education around all these different things, especially when things have passed or new opportunities are here and that information just hasn't reached everybody yet. So knowing that we have these meeting focus points coming up, now we can, in the agenda planning, part of that, we can make sure to have all of this information and to really gather what we know in these more specific areas to share prior to the next meeting or the meeting that we'll be talking about those specific things, so we can get on the same page and really understand the current opportunities and situation, and where we still need some changes and potential recommendations to happen. So we'll plan on focusing on the continuity of care transition from medical setting to community-based treatment, and noting the overlap with outreach to service connection at the next meeting. And the one after that, we'll take a look at changes to billing, credentialing, and how that could how we can change that to make things to leverage the workforce that we have, and provide hopefully a lot of links and information around what opportunities already exist in that space for anyone who isn't already aware. And Teresa and Eliza, I will definitely need your help with that. And I think that'll be a lot for us to work on over April. So I think we've got about 7 more minutes. Any ideas for a meeting focus after that, or just something that you want? Does anybody have an issue that they definitely want to make sure we have a meeting focused on in the near future?
So Michelle, I see on the screen, so that meeting focus, the second one, is it really also focusing on what can be done prior to intake? Is that what we're focusing on in that second area? And leveraging and expanding everything, is that? Because it's not just going to be SERI, right?
Brandy, I'll let you answer that question. Did you intend for that to be like prior to intake, or across,
It depends on the time we would be spending utilizing that. I really think it could be across the board if necessary. But I think it ties into continuity of care and between what can be utilized to effectively communicate between systems of care.
Okay. Does that answer the question, Teresa?
Yeah.
Okay. All right, I'm just catching up on chat. Maida says this may be splitting hairs around the assessment language, but peers in some of the outreach programs can determine eligibility for services based on suspected SUD or OUD, observation, self-report, or previous diagnosis. And so, Maida, what does like determining eligibility mean? Does that mean that they could refer to those services and then that like do a warm handoff, and then from there that service provider would do any kind of intake or assessment process with that patient, or what happens once someone's determined eligible for something?
Yeah, I think they would be, this goes back to what Brandy was saying, that they would be eligible for peer services and case management services and things like that. So not necessarily for intake into SUD services per se. But if we're talking about that sort of like greasing the skids to getting people into that intake, I just wanted to make sure that, because I know Teresa's saying definitely out of scope to do assessment, but there are certain types of lowercase a assessment that that peers can do to get people into some of those services that can help them get into SUD services. Yeah.
Okay. Okay, thanks for that. All right. Well, I think we've got the next couple meetings, topics sorted out. So I'll get to work with Kelly on agenda planning with those of you who have expressed interest. And we no real need to stay another 3 minutes if we're all good here. Was there anything, any final comments anyone wanted to raise? All right. Well, thanks everyone for being here, and we'll see you in April for the next meeting.
Thank you.
Thank you. Bye.